going to, progressing to IV heroin use. So it's something that we really need to be aware of and to, I think, destigmatize a little bit, because it's going to be such an issue and such a common thing as time goes on. Prior to this wave of prescription drug use, we didn't see that many middle-class kids who were using heroin. You didn't see it. You saw that in urban areas where people were, in these really tough places where you'd expect people to have, IV drug use. But now, more and more, we're seeing kids like Dave in San Marino, good family, where you wouldn't expect it to happen, but because of the physiology and the pharmacology of these drugs, this is the progression and something that happens. So I'd like to have a little bit of a discussion and hear from all of you about what could be done to have prevented this situation for him. Any ideas? Yes.
I would start at the beginning and address his anxiety disorder.
Yes. So addressing anxiety and stress is very, very important. Many people start out their addictions because they're self-medicating something. I think the number of mild cases of anxiety that are in this country is far above what's being reported. If you think about the average guy who goes to the bar after work, after a hard day, and wants to have a drink, a lot of people all across the city are self-medicating mild anxiety. Maybe it's not a full anxiety disorder, but mild anxiety can be self-medicated in this way, and for some people it can escalate. Anxiety can be treated in a variety of ways. It doesn't necessarily have to be treated with medication. Many people, for especially mild to moderate anxiety, can be treated with individual psychotherapy, with adjusting diet and exercise. And another thing that I like to talk about with my patients is maintaining regular healthy practices that keep their anxiety low. One of them is being involved with regular meditation or prayer. Meditation is something that has a variety of different forms, and it's something that I've spent some time teaching a lot of my patients, and I've actually brought some CDs tonight that I can give all of you that I made that teach some different techniques for meditation to reduce anxiety. Also for folks who are religious, I do try to explore their spiritual beliefs and try to encourage that regular participation in their beliefs. So if somebody might pray a rosary every once in a while, say, well, let's talk about praying the rosary every day. Let's do this as a regular thing, or let's do this twice a day. And those regular practices can be very helpful. What else can be done to prevent this from happening?
What about better education? It's been a long time since I was in school. I know when I was in school, there was a lot of education on the dangers of drug use. But how much education are they giving the kids nowadays?
That's a really great question. I think one of the problems with drug education is that drugs tend to be lumped in this big mass of it's all bad, and there isn't really a lot of discussion about how do these things happen. How does somebody go from taking Vicodin and end up on IV heroin? What happens when people smoke marijuana? Where does it go? To what extent is it causing problems for people? I don't think there's a lot of open discussion between faculty and students, and certainly a lot of times parents, especially with kids, around the age of this patient. A lot of the parents were, they lived through the 60s. They don't really want to talk about their drug use. They don't want to talk about smoking pot or dropping acid or doing some of the things that they did. And the reality is that the drug scenario is very different right now. The drugs that people are using now don't tend to be the psychedelic, experimental type of drugs. I mean, these are things that develop serious addictions, and one thing I didn't mention, which we really shouldn't avoid, is the rate of overdose with these medications. A really important thing that I like to remind patients about when they come into treatment, we don't want them to leave treatment. We don't want them to relapse. That's not the goal. The goal is to get sober. However, especially if somebody decides to leave treatment, I like to let them know that even though you were using 1 gram of heroin IV every day, if you go back onto the street and you try to use that same amount, or even if you cut it in half, if you go down to half a gram, you can still overdose from that and you can die. So this is a really, really dangerous drug. And it's...
That happens a lot.
Yeah.
With leave treatment. It happens a lot. Try to go back to using.
Yeah, and they know that they've lost their tolerance. They've gone through detox. They know they don't have the tolerance that they had before. That I can't shoot a whole gram of heroin now. I know it's gonna, that would be too much. But half a gram, maybe that would be okay. And because of the rapid escalation of the dependence on opiates, and because of the way that you so quickly lose dependence, the equivalent dose of what they would be using to get high would be very, very small in comparison. It's often 1/10 of the amount. So oftentimes they're just not aware of the kind of how this has affected their body and how their body has changed during treatment. So I do like to talk to patients about that. Not that I would, encourage them going back to it, but I do think it's important that they know, what's going to happen if they try to use again. Any other ideas? Yeah.
Can you comment? You made a comment earlier about the under-treatment of pain. Now, who's driving that piece? Is it the pharmaceutical companies or?
That's a really good question. So the literature is different depending on which journal is publishing it. In the addiction literature, there's a lot of emphasis on, opiates should never be used. People should just go out of the hospital and suffer. And on the other side, it's that, gosh, pain is it the 5th vital sign or 6th vital sign?
Fifth.
So pain is the 5th vital sign, and we need to treat it. And I think the truth is probably somewhere in the middle. We need to really look at the physiology of their problem, exhaust all of our medications that are non-narcotic, and then use narcotic medications appropriately for a short period of time. But there were big studies looking at pain treatment in hospitals, and those were some of the big results from very, very large studies that, in general, people in the hospital were throughout the 90s being undertreated for pain, and it tends to ebb and flow in these big fluctuations. We kind of overcompensate one way or the other, but that's a big issue. You'll hear about that if you hear talks from internal medicine or from pain management, although I think it's starting to go back the other way. At least at pain management at UCLA is very focused on looking at other medications, looking at using antidepressants to treat pain, which is another big area of research. If you're depressed or if you have anxiety, your sensation of pain is worse than it actually is. Yeah.
I've noticed a lot of physicians that we've worked with, or that we've encountered, that I think the problem comes from a lot of people classifying addicts and kind of stereotyping. A lot of doctors are like, I know my patients are not addicts, or, they don't think beyond it, like the situation with the grandma, like maybe she has a grandson who's probably abusing something. So that's kind of the issue that we're seeing a lot in treating pain. They don't believe that there's an addiction there. They think that only certain people are addicted. So.
Right, and there's also this syndrome of physiological dependence on opiates, which isn't necessarily addiction. So with these levels of OxyContin and other things that this patient was taking, he was taking it illicitly, but there are people who are taking these doses and they're being prescribed by their doctor, and they have all the same symptoms of withdrawal if they run out of their medication. So it doesn't discriminate between somebody who's trying to get high versus somebody who just is taking it for pain. You're going to have these same withdrawal symptoms, and it creates the same anxiety for everyone, worrying that they're going to run out of their medication. It's very, very tricky.
How about your middle-class housewife who has a tendency to read and she's got advice given by her doctor? The doctors need to be educated to educate their patients because they're just prescribing doctors.
Absolutely.
And they don't tell us that it should only be taken for a short time. It's their doctor, they are a well-educated woman, and she keeps going back for pain medication. After a period of a couple of months, she's addicted to it
Right.
and has to have it. And the doctors just keep prescribing it.
Right. So it's this.
6 years later, they're in a treatment facility, and the doctors prescribed it for 6 years.
Right. And here at Pasadena Recovery Center, a lot of times we will have people who come in and they're not your classic opiate addict. We'll have people who come in who've been treated by pain management, they've had their surgeries, they've had injections, and they're on huge doses of opiates, and they want to get off of it. They don't know what to do. So, it may not be a classic addiction, but they come in for addiction treatment to get off of this stuff because it's just too hard, I think, for them to do it as an outpatient.
But I think my point was that the doctors aren't educating their patients when they prescribe it.
Yes.
The prescribing doctor has to be educated.
I totally agree with you. I have this type of talk with my patients when I give them benzodiazepines for anxiety, that this is a short-term medication. If you use it longer than 2 weeks, you're going to start to develop a dependence on it. So it's for short-term or just for every once in a while. It's not an everyday medication. It just doesn't work well after a while. But it's interesting that you talk about the education, because this idea of pain treatment has been such an important thing that for physicians, in order to maintain our license, we need to have 8 hours of pain management treatment, 8 hours of pain management training every 2 years when we renew our license. That's part of our licensure. It's the only class that they require us to have in order to continue our license. But there's nothing about addiction. I think that's very telling about the way things are right now. So with this patient, Dave, he ends up going to treatment. He has multiple attempts at treatment. It's not a one-shot deal for him. He goes into treatment, has a lot of withdrawal symptoms, and just can't tolerate it. When we talk about this cycle, this is something that's very difficult for a lot of folks when they come into treatment. The anticipation of withdrawal is sometimes worse than the withdrawal itself, just knowing that it's coming. And that's when a lot of people leave. They may actually get to the point of having withdrawal, but a lot of times it's just the anticipation or just the idea that, oh my gosh, I don't have my drug of choice. It's like this, good friend that I had, and now it's gone. So that's a big piece of it. So multiple treatment attempts and multiple detoxes, ultimately became homeless, and was not the kind of person that you would think would end up on the street. Somebody from a good family, well educated. Here he was, at UCLA, wanted to become a doctor, but eventually he did come in and get detox, got treatment, and at this point he's been sober for about 5 months and he's doing well. But it's it's scary to see kind of how these things progress and how quickly they can progress for somebody who you wouldn't necessarily, or somebody you wouldn't expect that to happen to. So, I think that about finishes. If you want to get a hold of me and get more information, or if you want any of the references for the things that I talked about, I didn't have them all in here, you can
I have a
ask me.
question. I think that the overprescription here from the dentist was revealing. Has anybody sort of educated dentist? I mean, I know sometimes I've been given Vicodin when I've had a tooth pulled and I go, but I don't use it. But, I mean,
You know, most dentists actually don't do that. They're a little bit more conservative than most primary care doctors. In this case is a little bit different, but I would say in general, it's more the primary care where it's a problem. Because they're used to giving 3 months of medication at a time. They're not gonna see you regularly. So there's almost this, this idea that, well, let me give them enough medication so that they won't have to come in and call me, and I'll see them in 3 months. And this idea of educating the person when they're getting the medication, that's very important. Saying, this is what happens if you take this for more than 2 weeks at a time. I understand that you're having very severe pain, and we may need to use an opiate medication to treat you. But once you're on this for a couple of weeks, it's going to start to become difficult to get off of it. So you have to be aware of that. Any other questions? All right, great. Well, thank you so much. And I do have those meditation CDs. Like I was saying, I'll put them on a table in the back, and if you're interested in listening to it, they'll be there.